I can go ahead and start talking about what things we do in the United States that I think could be model legislation for Brazil and what can happen and be created in Brazil. I'm excited for this time for you guys because anesthesia outside of the hospital doesn't have it many places. I
Yeah.
know that there's a society for the International Federation of Dentist Anesthesiologists that composes of countries around the world trying to come together to be able to have a unifying voice and have those privileges extended to their local governments. I know for myself, I'm a dentist anesthesiologist, so I actually do general anesthesia in the dental office. And a lot of those places that I go to are very appreciative of that because it helps with access to care. It definitely helps where people couldn't get care before are able to receive care, especially the special needs population and the underserved population as well. I do think it's a beautiful thing that the society has come together. Your goals are in alignment to what would help your community out. And I do think you can make a roadmap that will help guide you guys through that process. I know a lot of times when people think about doing any type of anesthesia outside of the hospital, they get to be intimidated and scared. And I think it's unappropriate. It's unfortunate because they don't realize that the standards that are in place to have that provider in the office or in an ambulatory surgery center. And I think those benefits to perform those procedures in the office definitely can help out. We first have to start off with like the educational standards. In the United States, we have the Conditional Dental Accreditation, and it really spells out during the specialties, whether you're a maxillofacial or oral surgeon, or if you are a dentist anesthesiologist or a periodontist, what type of anesthesia training that you will have. And when you meet those minimum criteria, you've gained that experience to be able to conduct a safe environment. It doesn't mean that all providers will be safe, but it does mean as a whole, those systems are in place. And so if you have those standards in place, you can create that type of training environment to gain enormous amount of support and safety, even amongst your team. When you look at the facilities, you can have individual structures or bylaws within those facilities that require team training, team assistance, and running through the drills and the protocols and how you pre-screen patients. All of those things you can make and have control kind of at a smaller level so you're a little bit more nimble to have better and best practices. And what that does, it opens up an environment where your patients can be seen sooner and also have surgery time that is less because you become more efficient in your systems. And I don't think anyone is doubting that shorter anesthesia time equals safety. So you can build systems in place to create safer environments. I do know that sometimes when I work in the hospital, we have to share amongst different, we may have one video laryngoscope or advanced airway technology amongst several operating rooms versus in private practice, in an ambulatory surgery center, we may have 4 or 5 different types of advanced technology and equipment at our disposal, at our hands. So I do think you can create this environment that actually helps create safety and helps open up access to care. I think it's very important to look at the educational standards as a baseline on how you go to achieve that as well. In the US, there's studies that show that the actual efficiencies that are gained is about 20% faster, and also recovery time is faster for those patients, and also access to when they can be treated so that the disease doesn't progress into more disease. I know, and I work in different states in the United States. Each state is a little bit different, but in Mississippi, the wait time to even be seen in the hospital is 9 months. And in Virginia, it exceeds 9 months, and that's because of the COVID pandemic too. Where that if we're seeing this in an ambulatory surgery center or in an office, those same patients can be seen within a few weeks to a month. So that latency of time, definitely that disease state is progressing. So I'm hopeful that Brazil can open up some access to care for your community. So there's definitely about 5 different topics that I want to talk about. One is education. We have to make sure that we have sound education providers. In the United States, that's accomplished by the Commission on Dental Accreditation that's ran through the American Dental Society of Dentists, the ADA. Those standards are adjusted by each subspecialty, whether that's in oral surgery, perio, pediatrics, or dental anesthesia. They all have a set minimum standard that must be accomplished within their training. And so once those minimum standards are accomplished, it does provide for that provider to have the experience that is necessary to conduct good, sound clinical judgment when it comes to anesthesia and providing safety for their patients. As our programs grow, so do the standards. They're not static, they do adjust, but it has been proven that you can train providers in a safe environment. There's millions and millions of people that are treated with anesthesia in the United States. And the statistics of having an adverse event with a dental anesthesia provider outside of the hospital is about the same as riding a roller coaster ride at Disney World. They have comparative statistics that show that and illustrate that. And I think that does go back to the educational standards and making good, sound clinical judgment. The other thing is the facility itself. If you have, you create standards and protocols into your facilities, you can have mock oral drills that are done on a routine basis that challenges your team's knowledge and experience, and also the provider's knowledge and experience. And I do those on a monthly basis with every office team that I go into. And they really kind of help connect the dots between knowledge and experience. And you can adjust those things a lot easier and have those drills easier in an ambulatory surgery center than you can in a hospital. In a hospital, they do have very good structures. They are safe. I won't say that they're not, but you definitely have to conform to a bigger, more cast system, where in a surgery center, you can adjust the frequency and the time and how much you're investing into your own team. The same goes with capital and equipment. So if the equipment at the hospital is limited, you may have one video laryngoscope that's shared amongst many different operatories, versus in a surgery center or where I work, I have 4 to 5 different video laryngoscopes at my disposal at all times. Efficiency is also a big thing. And this opens up access to care because some people have to travel long distances to be able to get into the hospital. They also are in a big waiting list as well. Different states that I work in, it may be 9 months before you can get scheduled into a hospital. And some are exceeding a year because of the COVID pandemic.
Yeah, actually, there are huge differences between Brazil and US regarding the health systems.
Yeah.
Well, and I know, I don't know much about the peculiarities of the US systems. I know there are huge differences among states, for example, because you have strong legislation, protocols that vary a lot among states. While in Brazil,
Yes.
Brazil is not quite a conflict nation as you are in US, so we are more like a federative state, which means that the union, the federal government is very strong, and we have some legislations which are national, so they are applied in every state. But yes, we do have state regulatory legislations, for example, in enforcements, which can, I would say, like fill some voidance in legislation, and say, for example, that we can do some things in one state that we couldn't do in another states, for example.
I see.
And we have like a mixed health system in which 3/4 of the population are basically covered by the public health system,
Well,
which
that's
is
quite a
free
bit.
for everybody, but which has which lacks a lot in coverings,
Right.
especially the low complexity procedures, and especially for oral health, for example. I would say that they tend to allocate much more funds in high complexity, like trauma or like organ transplantation. And so as funding is an issue here, so it lacks money and lacks funding for these less complex procedures.
Right.
So
That,
oral health suffers a lot.
that's a good key point too, because I know we have studies in the U.S. where we show the savings that's incorporated with this is 10 to 13 times the difference. And I think that's a key point when you talk to your legislative powers, is saying we can open up access to care to people in a safe environment, and we can save the state millions of dollars per provider. When you
Yeah,
look down at the statistics,
we are talking previously today about this because a savings for us is a matter of democratizing access,
right,
much more than savings for example, for earning more money. So
right,
we're talking about democratizing access for everybody. And by the other hand, we feel that we cannot jeopardize the quality of the assistance by saving, just cutting
yes,
costs. So we must fight for standards and for minimum standards of quality and quality of care, so we can uh, increase the capillarity of the system, so
right,
we can treat much more patients with less money, but with safety, with quality. So the Sobracam fight is to bring this discussion to Brazil, which is something that is very solid in US, for example, and in Europe, but not just in these places. We had this morning a presentation from India, for example, showing that even in countries which has a profile very close to ours, that yes, you can bring ambulatory surgery standards in order to bring good health assistance in a budget for everybody. So, and I realized that you yourself, that you practice in a freestanding ambulatory facility, if I'm not
right.
mistaken, at least for what I saw and the chat we had. So I would like you to talk about safety in such venues. I mean, how to assure that you have the same safety standards and the same quality you would in a big hospital without the problems that a big hospital brings to the
Right.
systems. Yeah.
So I do not equate safety with money. You can throw a lot of money at something and not make it any more safer. You know, you have those big structures and those big buildings. Safety really comes into systems, and how do you manage your systems and how do you run your systems. And so when you are small and nimble, you can make and develop protocols for these facilities and these systems that really drive down the point of emergency management. How do you recover, and what are the tools necessary for that? I actually created an app called 10 Minutes Saves a Life. It is a crisis management app that's, I believe it's downloaded in 15 different countries, and we have about 30,000 users, and it's just been out for a little bit over a year. But it really drills down to the basics of what crisis events can happen in an ambulatory surgery center. And a lot of people are taking that as their protocol, be able to do drills and do procedures and do monthly logs with their team. Now, if you have a system in place with continuity of your team, it's not like when you go to a hospital, you may work with person A and the next day you're working with person B. So you do have a breakdown in your system and your structures with the hospital where your systems can be a little bit more efficient and stronger in an outpatient surgery center. The other thing to note is that as your disease process in dentistry is taking an absorbent amount of time to get scheduled, you have more complexity and more invasiveness into the procedure of the surgery aspect of it, which leads to more complications and risk of anesthesia of the system. To get a patient sooner, there's less trauma, there's less invasive of surgery, and less time of anesthesia on that patient itself. I mean, it's just shown statistically that the efficiency is about 20%. So if you do 20% longer anesthesia, 20% more invasive procedures, because you are in a hospital, that doesn't make for a safer system. Actually, it's the inverse of that. It's actually less safe than if you can have these little outpatient surgery centers to be able to help your patient population. And so I don't believe that money is the answer of throwing things to improve safety. I think your systems that are in place is what helps. And this cannot be more profound than what we've seen in general aviation. And what we've seen in general aviation is that we had a lot of accidents and a lot of deaths, and it was a scary thing to go flying, especially in the commercial airlines. And what ended up happening is that they decided to take NASA and a third party to have a reporting system for pilots to report exactly what they were seeing. And they aggregate that data, and then they brought it back to the people. And what you could do as a pilot, if you reported, you were protected. It was anonymous information. And because you reported, it helped you if you kind of got in a violation type of situation to a certain extent. Safety has dramatically improved 10 to 20 fold in a short period of time because they built a system in place to support the community and help learn within each other of the community. That's very cost very minimum is very efficient. So the cost of that is very minimum, and they have this system in place that we can learn as a community. It wasn't by building big structures or having over regulations. It was about actually creating that system in place for the community and for aviation. And I see that evolving into dentistry as well. There's a website called the Dental Patient Safety Foundation that's doing that right now.
I would just like to add to our audience that we're talking to an anesthesiologist who is also a dentist in terms of formation, a civil engineer, and an aviator as well. And so, and you brought some very interesting parallels between general aviation and surgery. And I like that because there are two main points that you could tell much better than me about that. But how we learn from accidents in order to be sure that they won't occur the same way. So, well, you have an airplane crash, for example, in which everybody died, for example. So why should we scrutinize everything that happens? Well, it's because we don't want that to happen again. So how to bring this to ambulatory surgery, which is done in much smaller structures than a big hospital, for example. So how to assure that we will scrutinize everything we do in ambulatory surgery in order to keep our patients safer. This point, and the other point from general aviation, which is the CRM, the crew resource management, which is something that was have revolutionized, for example, these once vertical aspects of the teamwork, in which the commander wouldn't listen to the co-pilot, for example. And so we have to listen to everybody, and then the teamwork in ambulatory surgery seems to be much more reliable, much more well-developed if compared to a big hospital, because the anesthetists know much better the surgeon or the dentist, and the nurse is the same, and everybody is just linked, bonded among themselves and to the patient as well. Could you comment a little bit on that?
Yes, so you're absolutely right. Crew resource management is a piece of the puzzle. Also, your systems and your structure is also another piece of the puzzle. Your staffing and your education, and you put all these things together, you start to see the big picture. You start to see, okay, this is what it takes to have our community in a very safe and efficient, cutting costs that compromises safety, but is saving the community a tremendous amount of cost and actually increasing safety at the same time. So you're absolutely right. And those parallels are there, and you can see them. If Brazil wanted to move forward with this, is the most critical aspect of all of this would be education. Is having the time, the face-to-face time like we are having right now, but to the key players to really understand and do a deep dive to make sure that they understand all of those elements. Because they're not very easy to really understand unless you really do that deep dive and you go into the literature and you see how things are evolving and developing. And fortunately for the US, we've done this for many, many years. We've done this for probably 4 to 5 decades, where we can kind of see our history from our past and where we've progressed to where we are right now.
I would like to approach to some technical aspects regarding specifically anesthesiology in a dental venue, for dental practice, especially regarding the use of supraglottic devices like a laryngeal mask, for example, when to use it, and especially when to put a nasal tube, for example, in order to make room for all dental procedures. Are there specific indications you would choose between these two choices? For example, I don't know, comparing elderly, children.
Right.
Talk about some about it.
Sure. So a lot of what I do is nasal intubations. And so I'll have a nasal ray where I intubate, which is out of the way from all the dentistry, and it overcomes all the obstruction. Now, you know, I'm an anesthesiologist with a lot of training and experience to be able to do that. It does help, and it doesn't fit for all patients. So if I have a more medically compromised patient that can't take the stimulation of having an endotracheal tube, I may do something that's less invasive, such as what you described as a laryngeal mask airway. And they do make those with flexible laryngeal mask airways where you can kind of get around and do some dentistry with it as well. I've seen it used with implant cases. I've seen it used with extractions. And then you may even back off a little bit more if the patient's even more medically compromised and do just what they call a natural airway or an open airway, where you're adjusting your level of sedation to fit the patient. I think the key element of all of this is that you don't make the patient fit your anesthetic plan. You make your anesthetic plan fit the patient's needs. And as long as you're able to do that, you do find yourself being able to provide a great service for patients. For instance, a lot of patients are going to go to the dentist without any sedation or any oversight at all. It may be very hypertensive. It may right be on the bubble or the edge of having a cardiac event or a crisis just by heart rate alone, when the dentistry doesn't have any idea about that because they're not monitoring vital signs. They're just doing dentistry in kind of their cottage industry, unbeknownst to them. So if you were to able to open up access to care where they can actually get some anesthesia without the encumbrance of going to the hospital, now you have a patient population that is going to be better served because you do have someone that's actually looking out for those things for them.
It's a great point you said about that patient, which is doing something very usual, the daily care, daily standard of care, which is going to the dentist and awaken being submitted to a procedure. And that events can occur because he's not being monitored, for example, and that just the dentist is not aware of what is going on with that patient, with the physiology of that
Right.
patient. He has some comorbidities, and maybe he wasn't evaluated by the dentist about that. So if you could talk about the way you evaluate these patients, is it you do it yourself in patients in which you will be the anesthesiologist in charge of the procedure, for example, or is there some
Right.
kind of teamwork and special protocols to evaluate these patients? So in a way that a colleague can evaluate the patient and then you can just be in the day, for example, and can rely on a colleague evaluation, for example, of the case.
So what we have to do is build safety nets, and that does involve a team, but it also involves me as the anesthesia provider making that final decision for that clinical judgment. So what typically will happen, a patient will come into the office, there's some anxiety or there's some indication why they need anesthesia, and it may just be for health reasons. The dentist may say, wow, I don't expect them to understand all of the human physiology, but they understand enough to be able to say, this is a patient that's a high risk, even just for local anesthesia. So they will fill out there and they will give it to me. And then I review all the questions, the health history of that patient. And then I'll consult with the specialist as needed. Maybe that's a pulmonologist, maybe that's a cardiologist or an endocrinologist. I'll start to gather that information with the team at the office because it's a team environment. So all the records are held in that dental home. And then I'll make a final go, no go decision on what the anesthetic plan is going to be, what the expectations are, and if we can do this safely, either in the ambulatory surgery center or if it has to go to the hospital because they may need aftercare monitoring and surveillance. That allows a lot of flexibility in the system. So you're working with the hospital and you're working in the ambulatory surgery or the dental office, but you're all working as a team that fits the needs of the individual patient. So it is a layers of different safety nets as a team, but ultimately as the anesthesia provider, you're directing those efforts.
Yeah, no, very nice points. And Brady, how do you assess the quality of I mean of the post-operatory and post-procedural general satisfaction of the patients with the service and the ambulatory surgery setting?
So we follow up on all the patients and we ask them about post-op nausea and vomiting. We set of questions like post-op nausea and vomiting, pain control, any bathroom issues, etc. And so all of those things are marked, and those are data points that we collect. In the US, we use a database called NACOR, and it aggregates all the information, and you can actually pull a lot of statistics from those data points to show like, well, how many laryngospasms has there been? Has it been managed appropriately? How many post-op nausea vomiting issues do we have? And that is in the surgery center, so you still get the same data that you would in a hospital setting that you can in an ambulatory surgery. I probably have time for just one more question, just because my flight is boarding right now, but I do appreciate this time, and I hate that I'm kind of in a crunch for my time today.
Yes, I look forward maybe to work with you again in a next lecture. It was great to talk to you. And yes, I do have a final question, which is about the audits. I mean, are you were talking about your internal audits, and are you also audited externally? I mean, by a sanitary maybe
Yes.
authority, for example, or even for the insurance companies, and how do you interact with these entities in order to to bring transparency of what you're doing in the ambulatory surgery?
So every state is different in their state laws with that. And I'm on 2 different state boards for their anesthesia advisory panels. And I know where we're structuring a lot of this, but there are audits done on a every 2-year basis where the evaluator is going to come over. They're going to review the records. They're going to review if you've done emergency scenario trainings with your staff. They're going to review your staff as well in their training. They're going to review your own credentials. And that audit happens every 2 years. And then there's also a pass, a conditional pass, and a fail system. So a fail means you are a danger to the community, you cannot proceed. A conditional pass is, well, you had some expired drugs, and I understand that they're on back order, but we need proof that you're making best efforts to correct something. It's not necessarily an identification to a patient harm situation. And then you have a pass if you've been able to successfully do that evaluation. A lot of those are volunteer basis, so it doesn't cost the community anything. What happens is we as a state say, okay, if you volunteer your time to go around and help do the evaluations for the community, you will be granted continuing education hours for what you have to fulfill. So there's a little bit in it for them as a gift, but it doesn't cost any money to the community. So it's a great way for the community to come together to watch out after each other. I want to thank everyone for your time. I really appreciate being a part of this, and I look forward to like seeing this through and seeing your progression and where this takes off. You guys have a lot to overcome, but I'm excited because you're right in the infantile state of all of this.
Brady, I was just on behalf of all my SoberCam colleagues, I understand that you are in a hurry, in very short time. So I'd like to thank you very much for giving us a little bit of your time, but a lot of your experience. It was certainly very enlightening for us. And I look forward to work again with you in the future. All right. Thank you very much.
All right. Thank you, guys. Have a great day.